we are back. Thank you for still being here. There are people who are from the morning here, so I really thank you, but people who will still join us. You can watch also on the YouTube, so we had some connection problems, but on YouTube it's for free. You can watch. We are live there as well. So the chapter of children and lifestyle medicine, of children and families in lifestyle medicine, it's something which came up and we are building up with Ourania. She's a professor, Ourania Kolokotroni. It's a pediatrician, a certified lactation consultant, and associate professor of epidemiology and public health at the University of Nicosia Medical School. She has a special interest in health promotion for children and recently qualified with the ELMO certificate. So there I had the chance and the opportunity to meet Ourania. And I really have to say that was one of the nicest professional meeting what I had. So please, Ourania, you are in charge of the chapter. Thank you.
Thank you, Ioan, and many thanks for the opportunity to meet so many people today and discuss about lifestyle medicine in children. What we are planning to do with a team of people this afternoon is to discuss with everybody the potential of adapting lifestyle medicine and expanding it to children. So I'm just going to share. So can you see my screen?
Yes, yes.
Yes. Okay, so children and families in lifestyle medicine for this afternoon. And I got this motto from the Nurturing Care Framework for Early Childhood Development, which is an initiative of the World Health Organization and UNICEF that advocates for investing in early life for children so that they reach their full potential, not just in health, but in many other areas. But it goes very well with health as well. So what it says is that when you change the beginning of the story, you can change the whole story. And this is what we are trying to do with lifestyle medicine in children. So what we will be trying to answer this afternoon with the whole team is how can we expand and adapt the field of lifestyle medicine to families and children? What approach should be used to implement lifestyle medicine for children and families? Who are the stakeholders who need to be included in this approach? And what are the educational needs of these stakeholders? And how can we meet this in order to enhance their practice of lifestyle medicine? So as I said, we've got a range of presentations. I'm not going to introduce people now. I think I'll introduce them as we go along for the interest of time. But I was very glad to hear the talk by Dr. Stefan Penman from Australia, because I think our kind of approach is towards what he was trying to describe, towards more like an approach that involves not just the child, their families, but also the communities and societies. So I'll start with my presentation first. And my presentation is what is lifestyle medicine for families? What are we proposing to do? So we've heard lots of definitions about lifestyle medicine today, and I am using the ELMO one, and I think by now you know lifestyle medicine is an evidence-based branch of medicine that tries to address the causes of non-communicable diseases. But what we actually know is that its application in children has received less attention. It's not that it's not happening. Individual components of it are taking place. For example, I'm a breastfeeding consultant, a lactation consultant, and of course, helping mothers breastfeed their children. it's part of lifestyle medicine because it reduces risk for non-communicable diseases. But what we're trying to say here is the application of a more holistic, a more comprehensive approach of lifestyle medicine in children. So why do we need lifestyle medicine in children? We need lifestyle medicine in children because we know that there is a rise in chronic diseases in childhood. So chronic diseases are starting early, and they're not only starting early, but there is a rise. The trends are increasing. The other thing that we know is that the risk of chronic disease development is affected by biological, behavioral, and psychosocial exposures, and all these exposures are happening across an individual's lifespan. But what's important to know is that increasing evidence in showing that this influence, it's very important in early life and that it's quite impactful, that early life experiences are actually impacting adult health. So the adoption of principles of lifestyle medicine in children provides this opportunity for greatest impact for the growing child and the developing child, but also the family as a whole. Just to start with talking about chronic diseases in children and looking at some information from NCD Children. This is a global multi-stake coalition that focuses on non-communicable diseases and advocates for the inclusion of children and families in the global NCD agenda. They also measure and they publish reports every year on non-communicable diseases in children. And what they actually show us is that the number of overweight and obese children under the age of 5 has increased by about 20% since 1990. Cancer is a leading cause of death among children and adolescents globally. Half of all mental illnesses begin by the age of 14. And if we talk about lifestyle habits, we know that a huge amount of adolescents, about 25 million globally, aged 13 to 15, smoke cigarettes. And if we just take obesity as an example of a non-communicable disease, and we just look at it globally, we see that there is an increasing trend both in boys and in girls. And if we take Europe as an example, 1 in 3 children are obese, and we know that the reasons why are obese are down to lifestyle habits that relate to nutrition, to physical activity, but other factors that we discuss under lifestyle medicine. And again, if we just see what is the actual prevalence of insufficient physical activity in children 11 to 17, we see that globally, even in low-income countries, but especially in high-income countries, we see that about 3 in 4 or even 4 in 5 children have insufficient physical activity levels, which is just one pillar of lifestyle medicine. So increasing trends of non-communicable diseases and lifestyle habits of children are in line of these increasing trends. So the important thing with children, though, is that the risk of developing non-communicable diseases starts early in life. We have focused a lot on the causative models for non-communicable diseases on other lifestyle factors, such as what we've heard so far today, but there is increasing evidence on the importance of early life exposures on health. And I think one of the first hypotheses that has been proposed is the one on developmental origins of health and disease, and the idea of biological programming earlier in life. So what these hypotheses suggest is that early life exposures lead to adaptive responses that affect long-term the risk of disease in children and into adulthood. So basically, what it suggests is that our exposures in early life, starting from even before conception or in utero, lead to phenotypic changes in children to enable them to survive. And these phenotypic changes lead to long-term health consequences. And if we just take the example of undernutrition of a fetus, which was the one that Barker proposed to begin with, is that if a fetus is undernourished in utero, then what happens that programs its metabolism. So when there is abundance of food, this leads to metabolic syndrome and coronary heart disease. So these kind of exposures in childhood are important, and are important because there are specific critical periods of growth and development where biological programming can take place through cytogenesis, organogenesis, metabolic and endocrine responses, epigenetic modification, or even the microbiome that we've heard earlier today. And these particular critical periods start before conception, in pregnancy, in infancy, later on in childhood and adolescence, which is kind of before we move into adulthood. So apart from the biological programming, there are also sensitive developmental stages for children. And during these specific changes from early in life through adolescence, we know that individuals acquire more easily social and cognitive skills, habits, coping strategies, attitudes, and values. And we need to be taking advantage of these sensitive developmental stages if we want to if we want to modify earlier their behaviors rather than trying to change them later on. And one example of this is that if we talk about eating habits or eating habits for children, what we know is that for children until the age of 18 months to 8 years, this is the time when their acceptance of novel foods is at its highest. But we know that after the age of 2 up to the age of 5, there is this concept called food neophobia, meaning that children are fearing novel foods. And this is the period when probably it is more difficult for parents to introduce new foods. So knowledge that they need to introduce new taste earlier is important for parents. And then what we also know is that food preferences change over childhood with repeated exposure. There is the parents influence the food choices and preferences of children by acting as role models. And as children move into adolescence, the influence from peers also comes in. So if we were to look at different kind of influences through the different critical periods that will, different exposures that will influence biological programming or the behavioral plasticity of children, starting from pre-conception to adolescence. On this slide, I just had a few examples of such exposures that would change a child's risk towards obesity, for example. So pre-conception, a high pre-pregnancy weight, we know increases the risk of child to become obese. During pregnancy, maternal overfeeding primes energy and appetite regulation in children. In infancy, we know that low protein content in breast milk has an effect on metabolism, but also the behavior of feeding in terms of responsive feeding and self-regulation of appetite that comes with breastfeeding. Moving on to childhood, there's a strong correlation between eating patterns of mothers and children, and also what kind of fats children have in terms of their lipolytic activity. And then moving into adolescence, we know that this is a period of independence and children eating away from home, and this is where peer preferences come into place. But what's important to know, and I think Beth Fratis also mentioned this at some point today, is that it is important that we do affect all of these stages. And adolescents are an important group to affect, because what we actually know is that if we manage to change their lifestyle habits, and then what happens is that they become the new parents. They have different lifestyle habits pre-conception, during pregnancy, and then they affect their children's behavior. So by acting in adolescence, what you do is that you move the new generation from a high risk trajectory for developing chronic diseases to a much lower risk trajectory for developing chronic diseases. So going back to this question, why lifestyle medicine in children? Because it adopts the model of primary prevention for non-communicable diseases by introducing changes and interventions that affect critical periods early in life. And it also takes advantage of the biological and behavioral plasticity for the reduction in the risk of non-communicable diseases. Now, how can we apply lifestyle medicine in children? Of course, we know that there are the different lifestyle pillars that we could work on. And what we've shared today is that we probably have more than the 5, the 6, the 7 different pillars that we can work. And we can work on these pillars at the different, with parents and with families and with children at the different critical periods, starting from preconception to pregnancy to infancy to childhood and to adolescence. Parents are an integral part, play an integral part in the process because children, obviously, and especially the young ones depend on them. But it's important for lifestyle changes to start as early as possible in life, and that's why parents are very important. We also know that parents' lifestyle habits influence the children's habits, so parents act as role models for children. And despite the fact that families consist of individuals with their own goals, the experience of a family as a unit, it's important in order to shape their lifestyle habits as a family and making lifestyle changes. So how can we actually work with families? Obviously, lifestyle medicine works with coaching, and family coaching has been proposed as a modality for an evidence-based prevention intervention. It's goal-focused, in line with family values and strengths. It leads to development of skills that lead to problem solving into challenging situations. It gives the opportunity for multiple risk factor change. It's flexible to meet families' priorities and is not stigmatizing for families. But beyond the family, what we discussed earlier in the education chapter is that how can we create enabling environments to enhance lifestyle medicine practice, not just in adults, but in children. I think we need to move from parents and families to also the community and the society setting, using the socio-ecological model for health and wellness. And this is what the rest of the speakers will talk about. They will talk about parents and families. They will talk about the school setting. They will talk about the opportunity to influence and create enable environments by working with medical school, with local healthcare authorities. And we can discuss later on how societies can get involved in this process of creating this enable environment that we can enhance lifestyle medicine in children. So what we're going to be discussing this afternoon is lifestyle medicine for families and children that is an evidence-based approach to shape the lifestyle habits of families, takes advantage of the biological and behavioral plasticity for children, focuses on different pillars of lifestyle medicine, uses a family-centered coaching approach, but also proposes a socio-ecological model to spread the lifestyle medicine practice to communities and societies. So thank you for your attention. These are just some pictures of my children and my family going on to different kind of places in Cyprus and enjoying the nice scenery of our country by doing some physical activity with not just our family, but friends as well. So I'll stop sharing now, and I'll give the floor to the next person who is going to present. And the next person is Ravzan Susan. Ravzan is a family medicine physician from Romania. He is assistant professor and head of family medicine discipline, as well as director of Center for Preventive Medicine at the University of Medicine and Pharmacy and at Timisoara in Romania. So Ravzan is going to talk to us about the lifestyle medicine education at the medical school level.
Thank you, Ourania. I will talk about the role of academia in shaping the future healthcare professional, changing the focus to lifestyle medicine for children and their family. In recent years, and also due to the ELMO activity, the interest in lifestyle medicine among health professionals, as well as in general population, has increased. In general, when health professionals talk about lifestyle medicine, it is about the role of the lifestyle medicine components in the prevention of non-communicable disease. We associate NCD only with older patients, but we forget that many of the lifestyle-related chronic disease have their causes in our childhood. The result is a first gap that can be solved by direct education or indirectly by education people who thought their activities can improve lifestyle in children and family. Who can provide measures? School at every level should be a source of information. Parents, if informed and educated, can lay the foundation of a healthy lifestyle starting in early childhood, and health professionals. The medical education today just started to improve chapters of lifestyle medicine in the mandatory curriculum regarding nutrition, physical activity, or addictions. Lifestyle for children is often forgotten or reduced to nutrition and physical activity without a global approach. How can we improve the situation? We need to first determine what this category of profession are. Professions focusing directly on lifestyle medicine, doctor, pharmacist, nurses, lifestyle medicine assistants, professionals focusing on the very specific commons of lifestyle medicine, like nutritionist, kinetotherapist, physical and occupational therapist, or professions where lifestyle medicine could be a part of their activity, like teachers, social workers, sport coaches. We need to check the current situation for each category. Analyzing the curriculum of medical faculty in Europe, the following general aspects can be observed. For medical related professions: absence of lifestyle medicine courses for students. There are postgraduate educational programs that approach different pillars of LM, which describe lifestyle medicine in general, but without a specific approach for children and family. Indirect interested specialties such as pediatrics and family medicine. The approach targets mainly nutrition, physical activity, or some addictions. In the medical specialties, secondary interest in promoting lifestyle medicine. There is little information about LM in children. In the medical specialties, there are less interest in lifestyle medicine in children, but which could have a role in lifestyle medicine. For example, cell biology, genetics, there is little information. For child-related professions in our country, teachers, coaches, social workers are not well educated to implement measures for a healthy lifestyle in children. There are no specific lifestyle medicine classes in the school curriculum. I would like to review some tools for implementing lifestyle medicine in universities. Elaboration of bibliographic material for lifestyle medicine for children and family. Establishing to whom, who address, and how we structure information according to the temporal objective, like Ourania said, preconception, pregnancy, infants, childhood, and adolescence. Getting information about the influence of pillar, about global treatment methods like communication behavior change tools, brief explanation on the meaning of every rule and the dedication of each pillar, and putting into practice. We need to assess the targets of these tools. The drop falling into water model highlights very well the distribution of lifestyle medicine information. In longitudinal sense, we need basal information about the influence of lifestyle medicine in preclinical disciplines that are discovered in time in form of simple information such as a rule of every pillar and in form of guidelines to be followed. For example, in cell biology, the influence of lifestyle on cellular components. In genetics, notions of epigenetics. Or in hygiene are important environment, pollution, and allergens. In transversal sense, we need specific pillar information in discipline secondary interest in lifestyle medicine for children and family. Integration of this information by including lifestyle medicine courses in pediatrics, family medicine, family planning, public health, or on the other hand, achieving independent disciplines. We need treatment opportunity in lifestyle medicine like a total entity, view as a total whole entity in a discipline that deal with the relationship with the patient, with a specific approach for disciplines with impact on the child and the family, or with a global approach for pediatrics and family medicine. Disciplinary secondary interests on lifestyle medicine are gynecology with preconception, pregnancy, obese pregnant woman, gestational diabetes mellitus, neonatology with breastfeeding, cardiology with individual and family physician activity, childhood hypertension, pneumology, gastroenterology with different pathology, nutritional disease with obese prediabetes in childhood. Other specialties involved can be orthopedics, endocrinology, sexology, ophthalmology, with computer vision syndrome, especially now with online schooling. Neurology with brain development, psychiatry, psychology with preconception, with addiction, pregnancy and infants for breastfeeding, sleep disorders, eating disorders, addictions, especially in adolescents. Where do we use these tools? For students, we can introduce regular or optional self-contained courses. The disadvantage is overloading the number of hours related to the preparation of students above a maximum load. In this respect, must be rethought the opportunity of other optional courses may be less important than lifestyle medicine. We can introduce students, teaching students, involvement of students during college through lifestyle medicine club. On anniversary days like lifestyle medicine days or stop smoking day. Setting challenge where students may notice the new problems that arise in the child's pathology, which may require intervention, like new prediabetes and hypertension in children. Regarding postgraduate education, we can introduce master for graduates of lifestyle medical related professionals in children's, master for LM coaches with special education on childhood, courses and practical activities for residents in pediatrics and family medicine, postgraduate training, online courses with educational support, conferences for students and residents, conferences for all health professions with emphasis on children and family. Perhaps more important than theoretical knowledge is moving education to practice by collaborating with people, coordinating of process targeted to young people and their family. Group activities for students and residents and children, students and residents and children or teenagers. volunteering for pregnant women, social groups for different lifestyle managing objectives, building a network or platform under ELMO DOM for interested teachers, or introducing a lifestyle register for the children, a lifestyle scan, and reanalyzing it after certain periods, measuring the efficiency of the interventions. Our experience. In our case, we started taking a few steps. After attending the first ELMO Congress, benefiting from the experience shared by the participants, some of them academics at faculties in Europe, we started to organize postgraduate course at our faculty. We introduced notions of lifestyle medicine in the curriculum for medical students and nurses. We started carrying out license theses on LM themes with focus on children. Noting the importance and the impact of lifestyle in our families, we decided to organize a conference on lifestyle medicine oriented towards childhood, first for resident doctors, then for doctors of different specialties. Some looked at this initiative with some distrust, but others have had a favorable attitude and seemed really interested. I have noticed that particularly younger doctors were more interested, understanding quickly the impact of lifestyle medicine on children. In addition to family physician and pediatrics, doctors from different specialties were interested. After some classes of brainstorming, the creation of social media groups was discussed. Some perspectives of lifestyle education in Romania are including lifestyle courses in university curriculum, but it's difficult due to the large number of hours and to lack of awareness of lifestyle medicine importance. Introducing master programs could be the solution for the moment, in our opinion. And we want national cooperation with other universities or associations like Romanian Medical Association for Preventing Through Healthy Lifestyle for the introduction of lifestyle medicine in the curriculum. In conclusion, introduction, the study of lifestyle medicine in a serious, complete, and uniform way lead to achieving good primordial or primary prevention, relieving of medical specialties, increasing life expectancy, increasing healthy life years, and decreasing disability-adjusted life years. To achieve all this, we need to introduce lifestyle medicine study in our university. That is why we need concerted effort at national and international level to put a little positive pressure on decision makers. Thank you for the audience.
Thank you, Razvan. Thank you very much. I think you touched upon a lot of the things that we discussed in the education chapter as well, in how we need to influence decision makers in changing the curricula for future healthcare professionals, and not only those, but also other professionals that work with children. So we will move now to Annie Kistari. Annie is a physician who is from Georgia, but currently she lives and works in Denmark. She's a public health specialist and a lifestyle medicine advisor. And Annie will talk to us about the role of family and also the role of community in children's healthy lifestyle. So Annie, thank you very much for participating. I think Razvan needs to unshare his screen.
No, Ourania, we actually see you now.
Okay, do you?
Yeah, we do see you.
Yeah, I would like to share my screen.
Okay, share your screen, okay.
So can I share my screen, Ourania?
Yes, you can share it, yes.
Okay, great. I hope you are all seeing my screen right now.
Yes, we can.
Great. So I'm gonna take a few minutes of yours to talk about the role of family and community in children's healthy lifestyle. Children's lifestyle habits play immense role in physical health and healthy development, as well as mental health of children. Lifestyle habits are formed in early childhood. They are difficult to modify in adolescents and adults. It has been demonstrated that lifestyle interventions are more effective in young children and less effective in older ones. The family system that surrounds a child's domestic life will have an active role in establishing and promoting behaviors that will persist throughout child's entire life. And according to family systems theory, the behaviors of one individual cannot be fully explained in isolation from the larger family unit. The psychological stress in mothers, it has been demonstrated, that psychological stress in mothers may play a role in parenting style and mother-child interactions, and may also lead to elevated cortisol levels in their children. Recent meta-analysis concluded that children of mothers experiencing high levels of psychological stress are also at a greater risk of obesity. Parents and their children's lifestyle factors are largely interrelated. It has been demonstrated by multiple studies that parental obesity is an important risk factor which contributes to childhood overweight and obesity. Both genetic and family environment factors are important. Parental physical activity is strongly associated with physical activity levels of their children. Offspring of parents who smoke have an elevated risk of smoking. Children who grow up under parents suffering from alcoholism are 4 times more likely to develop this disorder. Living with parents with substance use disorders is a complex issue, with children experiencing a wide range of negative outcomes, and including susceptibility to substance use disorder themselves in the future. Sleep patterns of family members are connected as well, and parents and children's sleep very much align. The role of grandparents, I mean, first of all, it's the grandparents, you very well know that they play an important role across the world in participating for caring for their grandchildren, and their role is not entirely clear. There are some gaps in the research, and some studies point out adverse relationship between grandparental care and healthy lifestyle habits. Some grandparents may unintentionally employ unhelpful feeding practices, such as using food to regulate emotions, restricting access to certain foods, spoiling or treating their grandchildren with food, using food as a reward, pressuring grandchildren to eat more, making high-fat and high-sugar foods available, allowing grandchildren a high degree of input and control when planning meal times and food choices, and providing less encouragement of a balanced intake than parents do. And there's a huge need to support grandparents and design interventions targeting them as well. Here you can see some of the factors which influence children's eating habits, and at higher level they are related to parents and family, community, demographic, socioeconomic status, food, and characteristics of the child, him or herself. I will not go into too much detail in that. Family functioning, cohesion, conflicts, communication, socioeconomic status, parental practices, and parental style have a lot to do with forming children's healthy lifestyle habits. Children's ability of imitating the actions of the others and learning by observation, in particular from their parents and caregivers, could explain the kind of lifestyle habits developed. Children model themselves on their parents' healthy behaviors, lifestyle, eating-related attitudes, and satisfaction or dissatisfaction regarding body image. Out of 4 parental prototypes that have been currently identified, authoritative is the most advisable when it comes to healthy lifestyle formation, healthy lifestyle habit formation. And authoritative or democratic parenting is characterized by by reasonable demands and high responsiveness, While authoritative parents might have high expectations for their children, they also give their kids the resources and support they need for success. Parents who exhibit this style listen to their children's love and warmth in addition to limits and fair discipline. This approach to parenting avoids punishment and treats and instead relies on strategies such as positive reinforcement. It's worth mentioning that parents' attempts to restrict their children's eating to reduce weight and maintain health may lead to the development of obesogenic eating behaviors in children, such as emotional eating and tendency to overeat. Here you have some of the strategies to improve children's eating behaviors, and you can see that activities such as eating together, avoiding using food as rewards, planning meals together, a minimum of 3 meals a week is recommended to form healthy eating habits, promoting self-regulation, authoritative parenting styles that I have just mentioned, family meals, exposure to a high variety of foods, as Ourania has mentioned.
Annie, if you can just be a little bit closer to the microphone, because at some point we cannot hear you very well.
Okay. Other activities are parent-focused intervention in the family environment. So parents have a very difficult role when it comes to formation of their children's healthy lifestyle habits. They are an example. They model good habits of their children, and they must be very much aware of these and pay attention to own reaction towards food, bring only healthy food into their home. Sharing meals at home and creating positive mealtime experiences is very much needed. Parental controls should be avoided, not to hinder the child's capacity to develop adequate self-regulatory eating practices. However, within an obesogenic society, a kind of moderate control is needed and desirable. When it comes to teenage healthy lifestyles in parenting, it's worth to mention that these adolescent lifestyles are somewhat autonomous during adolescence. It is very likely that they will last throughout their life, meaning that they must be involved in the decision making and own the decisions, and this will result into them adhering to these habits. It is important to use dialogue as a strategy to resolve discrepancies between adolescents and their parents, and the frequency of the personality parenting style to promote adjusted adolescent behavior autonomy and quickly maintain healthy lifestyle in the long term. And here are some of the barriers to parents, for parents to influence the healthy lifestyle habits formation of their children, which are lack of time, lack of energy, low socioeconomic level with lack of information and awareness and education, lack of finances, and as well mental health. So recommendations, parents and caregivers' competence and skills need to be scaled up in health promotion practice and research agenda, and along with these policies must be changed to support and empower parents to bring up future generations and healthy lifestyle habits. And last but not least, I would like to say a few words about mental health and lifestyle. The disease burden is huge, and it's even more to expect in the coming years. We see some pre-COVID pandemic data, which in 2011 was reported by the World Economic Forum and the Harvard School of Public Health. According to them, their mental illnesses was listed as the 5th major group of non-communicable diseases, together with cardiovascular diseases, cancers, respiratory diseases, and diabetes. And it was estimated that by 2030, the global cost of NCDs will be $47 trillion, and mental illness alone is predicted to cost $6 trillion, making it the most expensive NCD. So here is a study which was published in Pediatrics last year about lifestyle how lifestyle affects children's mental health, and they have studied 9 behavioral behaviors
such as intake fruits and vegetables, grain products, milk and alternatives, meat and alternatives, saturated fat, as well as added sugar, and habits such as physical activity, sleep, and screen time. And the more recommendations out of these 9 which were met, fewer physician visits were observed for mental illnesses, and completion of each of these recommendations actually reduced by 15% the likelihood of them visiting mental health professionals. That's all from me now. Thank you very much.
Thank you, Annie, for your presentation. I think you made a very good point of how families and parents especially can affect the lifestyle habits of their children. And you get some very nice examples there for everybody to think about. Let's move. We've got a few questions, and I invite people to write even more. We can discuss at the end. The next speaker is Aspa Gandili. Aspa is she's from Greece, but currently she works and lives in Netherlands. She's an educator and a sleep consultant and also a breastfeeding educator. And Aspa is going to talk to us about promoting health literacy in children and adolescents, and how can the teachers and the school leaders and educators help in this process. So, Aspam, the floor is yours.
Hello, thanks for having me. I'm going to share my screen. I hope you can all see it.
Mm-hmm. Yes.
Okay, so today I'm going to discuss what can we do to promote lifestyle medicine in schools. I'm going to start with this quote. It is from the ASCD and from the CDC, and it says health and education affect individuals, society, and the economy, and as such must work together whenever possible. Schools are a perfect setting for collaboration. And I added this quote because this is like a major theme in my presentation. So I want you to keep that in mind. It is from the whole school, whole community, and whole child approach, which I'm going to discuss a little bit later on. So I'm going to move on to the next slide. So why school is so important for health promotion? It is important because it reaches a large proportion of the population, and it does so for many years. It can promote health equity by offering equal opportunities to all students. It doesn't matter what your background is. In the school, you have access to health services and you have access to information much like everybody else. And health literacy and behavior begins at an early age, as we saw also from other presentations. There is a link between what education can do for your health and what health can do for your education. So education can create opportunities for better health, and poor health can put education in risk. And there are also a few factors that affect both education and health, which are social policies and individual family characteristics or the communities. So health promotion in schools usually focuses on healthy diet or prevention of obesity, addictive substances like alcohol, tobacco, and drugs, sexual health, mental health, and physical activity. I want you to look at this slide. I have put on top the old model of school health promotion. This is what we used to do. We focused on classroom teaching and passive learning. So we just laid out the facts. We taught children what they should and shouldn't do, and we expected to get an outcome. We expected them to have the knowledge to apply it in their lives. We addressed health issues one by one. Some schools still do that, by the way. We focused on students' needs, so we never tackled the whole school. And most of these actions were school-based. The new model of education, this is something we've been working on in the last decade or so, focuses on all aspects of the school community, health education inside the classroom, a health promoting environment by having the schools built in a way that can promote health, and services for children, for students. It addresses more than one issues, usually using a holistic approach to health. So this looks more like the lifestyle medicine perspective or approach. And it focuses on the health of the students, the teachers, the school leaders, the non-teaching staff, and the parents. And it focuses on the school in the context of the local community, just like it was mentioned in the previous presentation. A child doesn't grow in a bubble on its own. It grows within a family and within a community. So I put here why health literacy is so important. For most of us, it's self-evident, but I just mention it. It gives you the tools to understand nutrition as well as other habits. It can help you navigate the health system. It can help you know where to look for support and seek support. It can help you understand medical instructions, help you analyze risks and benefits of treatment, so you as a patient can be the expert of your health. It can help you organize healthcare appointments. I'm sorry. And it can also help you complete paperwork. So instead of being somebody who expects to go to the experts, it gives you all the tools to take health as your own responsibility. The Schools for Health in Europe have asked many educators about the potential barriers of this approach to health, because some schools have already started applying this health promoting approach. So they have some input for us, which I think we should take into consideration. So most of the educators have mentioned that lack of time, energy, and training for teachers are the biggest obstacles. Too many simultaneous projects in schools. This is an obstacle that the teachers have, but also the students have. Health promotion projects are considered by many schools as additional activities. It was mentioned earlier that there is no individual subject on health promotion, but teachers say they don't want that. They don't want to have an additional activity on top of everything else they are teaching. So it needs to be incorporated in the whole curriculum. The lack of support and low health literacy of parents and of the community are also important barriers. Not enough specialists from different health thematic areas to support health promotion projects. Since the teachers don't have the training, they would have liked to see specialists coming in the classroom or in the projects and sharing their knowledge. Limited interaction between the ministries of education and health. And schools' lack of understanding about benefits from participating in health promotion activities. There is a review that came out this year that says that 29% of school leaders in Europe, in some schools that they surveyed in Europe, didn't have a good understanding of health literacy, and they didn't incorporate projects to promote health literacy because they couldn't understand why they should do it and what should they do. Some examples of school models that follow this holistic and integrative approach to the promotion of health are the health promoting school, which is endorsed by the World Health Organization. You can see what the key features are on the screen on this small house and on the right part of the screen below. It says engage health education and community leaders, provide a safe, healthy environment, provide skills-based health education, provide access to health services, improve health promoting policy and practice, improve health of community. We have seen through systematic reviews that in high income countries, this health promoting school has managed to reduce risk factors for NCDs, non-communicable diseases. And it's also improving children's BMI, increasing physical activity, they increase fruit and vegetable intake, and it helps reduce tobacco use. Another approach is the whole school, whole community, whole child. This is from the ASCD and the CDC in America. You can see this graph that shows the student at the center, and around it comes the community, the family, the health services, counseling. So it resembles this graph that Ourania shared earlier on about having everybody involved in health. There's also the network with Schools for Health in Europe. This is a great resource with lots of information and lots of insight of what is happening in European countries, which is very important to use when we're thinking about the different ways to promote health promotion. And I've also added the trauma-informed schools. This is the HEARTS model, because the trauma-informed school is mostly focusing on mental health, but it has this idea of bringing in the community, offering training to teachers. It has been used for a few years now, and it promotes health equity, mental health equity, because it focuses on every student, but from a trauma-informed approach, so as not to re-traumatize students who have experienced or are still experiencing traumas. So here you can see what the most effective approaches are. Oh, there's one missing, which cannot see what I have put here. Collaboration from the community, I believe it is. Long-term projects encompassing all different stages of childhood, engaging the parents, peer support, holistic programs, engaging the whole school, even employees who are not teaching, educating the school leaders to bring about change, building relationships with the communities, and trauma-informed perspectives is the last one. And what could the ELMO do? They could create guidelines on transforming a school into a lifestyle medicine school. We already have these models of the whole child school and the trauma-informed school. This could be combined and create a lifestyle medicine school. Create resources like lesson plans, projects, posters, things that educators can use immediately in their classrooms, in the educational settings. And this is something that is done also by museums around the world or organizations, so it's very helpful. Reach out to other organizations that have a holistic approach to health promotion. Schools for Health in Europe is a great network. I have added AceAware NL, which is a project I'm working on with other colleagues, and we are discussing trauma-informed approaches to education and health. Create trainings for parents, educators, and school leaders. Create podcasts and videos using lay language that children and adolescents can understand, and also have an active media presence. Create graphs, pictures, posters, infographics, anything that can make the content, the goals of a lifestyle medicine, the lifestyle medicine chapter information easy to digest for the younger generations. And lastly, launch essay contests, art contests, video competitions. This was done by the European Union when we were starting working together, and it can be applied in health promotion, because children have great ideas to share. And if we ask them, what would you like to see in health promotion, we might be surprised by what they have to share. So this ends my presentation, and thank you very much for listening.
Aspa, thank you very much for a very inspiring presentation on how schools can help in creating an enabling environment to promote lifestyle medicine practice. So thank you very much. That was very good. And I think you start talking about the use of technology, the use of social media, which kind of brings us to the last presentation. And I was actually very glad to hear earlier from the education group, Dr. Stefan Penman again talking about the use of technology. So our last presentation for this group comes from Eleni Brifti. Eleni is, she's also from Greece. Eleni, she's also from Greece. But she works in Netherlands. She's a lifestyle medicine advisor and an expert in environmental health. And Eleni will be talking to us about social media as a tool of health communication in parents. So Eleni, the floor
Thank you very much. So I can share my screen. Okay, let me here. Can you all see it?
Yes.
Okay, all right. So hello, my name is Eleni Brifti, and I'm here to talk to you about how we can use social media as a tool of health communication to parents. Sorry, yeah. So health communication through social media has many advantages. It can be effective, and actually nowadays with all this coronavirus misinformation spreading through social media, we know that the effectiveness is even dangerous sometimes. It can be a low cost, it can be inclusive, it reaches most of socioeconomic levels, and this is how it actually promotes health equity. Nowadays, we have enough evidence showing us that this is a very good practice to look to. And here I'm just quoting the conclusions of a chapter to this book that has a big part for social media in health communication. It is said that the discipline of applying social media in health communication will continue to work and develop at fast pace over the coming decade. And that's a book just from last year. What about parents' engagement in social media? So are parents a target group that we can use social media to transfer health information to them? The answer is yes, and actually we have a lot of studies showing that parents are one of these community groups that use and engage with social media much more than other, definitely much more than non-parents. For example, on this study here of 2015, the conclusion said that more of 80% of mothers declare that they get useful parenting related information and support from social media. Which type of platform, do parents use more? I mean, is it all kind of platforms like Facebook and Twitter and everything that we could use to address to parents? We have to think of parents' needs. We have to remember, I mean, the ones who we are parents, we know that nothing has ever prepared us for parenthood, okay? We may be academics, but we were totally unprepared when we had our kids. So the Facebook platform is the one that actually answers to most of these community needs. Maybe you have heard the Chinese quote which says that it takes a village to raise a child. So today this village is online. That's why a lot of studies show that Facebook and specifically Facebook groups have a very high participation and engagement among parents. And here I'm gonna just show three of examples of parenting groups that have a huge participation and engagement. Anyone who is a mother in Netherlands knows the Amsterdam Mamas Facebook group. It has more than 19,000 members and thousands of questions every day. The Attiki breastfeeding support group in Greece, it has more than 43,000 members, and again answers to thousands of questions every day probably. Then we have a really impressive number of participants, of 126,000 of members in a child and infant nutrition Facebook group in Greece. So here, I just chose one of the studies that I found about using Facebook for obesity prevention curriculum, that at its results says that Facebook was found to be a feasible platform to provide nutritional education and facilitate varying levels of parental engagement. So here, I'm gonna talk to you about a very inspiring example of how to use social media, especially Facebook groups, as a health communication tool. It is the National Network of Voluntary Support Groups on Breastfeeding and Maternity of Greece. It was founded more than 10 years ago. It consists from 45 Facebook groups. It has more than 65,000 members. It's all women because it addresses the support towards breastfeeding and maternity. It has more than 200 volunteering admins answering daily to hundreds of questions. And here I really want to point that out, that these admins are people who have volunteered to promote and advocate about breastfeeding in Greece. And they are there day and night. I mean, they have answered my questions of breastfeeding at 3 a.m. And one of those admins is Aspa Gandilio, so that she talked at the previous presentation. They have also provided hundreds of translations of evidence-based articles to help the non-English mothers of Greece. They have organized seminars with experts like pediatricians, midwives, lactation consultants, psychologists. And for more than 10 years, they organized the breastfeeding festivals that had a very wide media coverage. I'm just noting here that I'm personally forever grateful for their support since 2016 that I am a breastfeeding mother. Barriers that we have to overcome when we use social media as a tool for health communication. If we want to reach out to as many people as possible, and if we want to reach out to all educational levels and all socioeconomic levels, we really have to overcome the barrier of language and the barrier of terminology. We really need to produce material in as many languages as possible, because we know that even if parents have some use of English, if they are not proficient in English, they will probably not be very easy to find and read article in English when they are tired at the end of the day and they are on social media. So you really don't want to stress when you are on Facebook, okay? The other barrier we need to overcome is the terminology barrier. Even when we have people that have a high educational level, that doesn't mean that they understand the phrase intake of saturated fat should be less than 10% of total energy, and intake of trans fat less than 1% of total energy. That is a phrase I have just copied from WHO website. And what I think we should do when we use social media is to take the example of the Eat Lancet summary report and produce visual translations of this terminology language. So we can say, for example, like that report says visually, that for an average person that needs 2,500 calories per day, the daily amount of red meat should be about 14 grams, 0 to 28 possible rates. So this explaining the terminology will really help us to not continue to be like what I'm showing here to the picture that I have put. I mean, scientists talk about apples and the public understands oranges. And finally, some ideas to go forward. We can produce easy visual infographics in many languages with cultural appropriate examples. And this cultural appropriate, I think it's very important because you have different type of lunches, for example, in Greece, in Cyprus, in Netherlands, or in Romania, I guess. We also need to produce videos and podcasts in as many languages, local languages, as possible. We can host live online seminars with local experts under the umbrella of ELMO. Then this, I think, out of the four ideas here, this is the one that I want to stress more, that we can reach out to the admins. We have to understand that till today, academia has kind of been blindfolded about this new way of communication. And as a friend of mine was telling me, she's working at a human resources position, she was telling that these volunteers out there are a huge human resource, which is left, abandoned to the ones that promote misinformation, pseudoscience. So if we reach out to the admins of the influential parents group, and we train them and we persuade them to communicate correct health information, then we will have a very big benefit. And finally, we can follow the example of the breastfeeding network of Greece and create our own ELMO online groups network, both for parents and for professionals that are willing to advocate and volunteer towards that cause. And I'm just gonna thank you, closing with my favorite quote of Nelson Mandela: health cannot be a question of income, it is a fundamental human right. And social media really gives us the tool to reach anyone with a very low income. Thank you.
Thank you, Eleni. Thank you very much. I think you've demonstrated really well how we can use social media and how we can use technology these days to promote the activities of lifestyle medicine in children. So we do have a few questions that we want to address. Let's go to the questions first, and then we can always I've got a few comments as well, and I'm sure you as panelists have on each other's presentations. But we'll start with the questions or comments. We have a comment that WHO School of Health network in Europe is very important, integrated part of ELMO network, collaboration. We should try and collaborate in the future. That's a very good point. Thank you very much for the comment. Adamandia Maliar from Greece, she's talking about the benefits of breastfeeding, and we are all very much in agreement that breastfeeding, and I think I've touched upon it in my presentation, that if we were to discuss the different critical periods in infancy, the breastfeeding as a means of nutrition, it's the best start in life that a child can have. And then we have another, and we have a question, I think it's for you, Eleni. How can evidence-based communication compete with the multitude of resources of questionable quality?
Yes, so I'm going to share my experience here. I am personally an admin in one of these groups, okay? And what I have seen is something that another friend of mine who is an expert in social media has told me, that social media is a weapon, okay, is a huge weapon. And but a lot of the people out there are really searching for evidence-based. So if we translate in the language that they can understand, they can filter. I mean, we should not see the public as, you know, a dumb pack of people that cannot filter. I do believe that science right now has left this weapon to the ones that cause damage. And this is what I believe, that we have to claim that weapon back. We have to make our voice heard. I mean, even Nature, if you have seen the Nature journal, has created a very strong social media platform now, and they are sharing. And so we can do the same. And I think that if we do the same, we will fight back to the misinformation. And lastly, I also believe to what I said about the training. So there are some key personalities to its society, at least coming from the Greek society, that I know that there are some more influential people out there on social media, okay? So if you approach those people with empathy and love and care, and you just want to talk to them and you train them to try to communicate evidence-based information and not get stuck, you know, to some guidelines that come from 1980s, then I think we can do a big impact.
If I may add up also my perspective.
I really liked your idea. Sorry, yes, Aspa,
Yes, I would like to add my perspective from the education field. I was working in a school, in a middle school, and we taught students how to filter news. So a lot of this work can be done in a school level. If, for example, the ELMO decides to create resources for teachers, they could show how do you get an article, for example, and you dissect the evidence-based information versus what is pseudoscience, what is what is promoted by other industries, and teach them how do you check for who wrote what, where does this author come from, is this a national guideline, what is wrong about this information that you're presented with, so that the student is taught how to look out for some stuff like that and how to find where the right information is. Then we will have a next generation that will be better than our generation that just came in the social media unprepared.
Yes, no, that's very true. I mean, if I share an experience we have in Cyprus, what we have done with a huge group of colleagues here in Cyprus was to create a free website for parents based on the Baby Buddy app that was developed in the UK. And that particular website we developed using participatory action research. That means that we asked parents to get involved. We asked healthcare professionals locally to, first of all, to find out what their needs were in terms of their education on health matters. But more importantly, what we did was to make sure that all the material that was shared there was evidence-based and that it was endorsed by both international, the information that was endorsed by international and local healthcare organizations. So in this way, what happens is that the different Facebook groups now in Cyprus refer to that particular page when they want to, when mothers are asking questions, because they know that it's evidence-based information that they find in that website. And I think maybe this is what, and I like what Eleni kind of suggested, that maybe we should have some ELMO material where that we use or we develop on the ELMO website a particular site where we have information for parents, for families, that they can be shared amongst these Facebook groups. So that's a very good idea. Now, I think I'm just trying to see whether we have any new questions. But I think no.
I receive a question from Eleni about non-updated information in lifestyle medicine area. I think the first step is to identify this wrong information, and the next step could be to inform the health professionals, all the health professionals involved, through up-to-date courses or online courses with focus on this old concept need to be changed. We need these specific courses targeted to this wrong concept. That's all.
Thank you. It is a challenging task to do. Yeah, but I understand. Thank you.
Welcome.
Annie, and question for us, actually. I'll go to Annie first. And I was kind of thinking, what about when we talk about adolescence, because you did say that it's a difficult period, again, to change habits. And we know that the peers' role there is very important. Sometimes. So what is your experience in that? How can we use the peers to model the lifestyle behaviors for adolescents?
I think that's a pretty complex matter, and it goes beyond many times goes beyond family control, and many times you realize that peers have more authority or more influence over children than family. So it's cultural norms created within the peer communities. So I have not gone into this question when preparing my presentation, and I think it's the whole new world which might, if we go into that, we might find some new areas which need exploring. So I'm afraid I don't have a question for you, answer for you.
Okay, thank you. I mean, I know that in the UK, for example, they used some the other, apart from peers in adolescents, what kind of work was also using some role models for adolescents, like, you know, famous singers and so forth, to model sometimes the behavior. So that's another thing that we could try and work on. Okay, and I have, yes.
And it has very much to do with social media, I think, and it's many times we as parents are kept outside of this world. It's whole parallel world which needs to be explored. And perhaps Eleni, you can add.
Yes, Ourania, can I add something? So to my experience, what really works great with adolescents is to talk to their inner tendency to fight for the rights of the planetary health, of animal advocacy, empathy to all beings. So the concept of eco-literate that Daniel Coleman describes very nicely, along with the emotional intelligence. So now we have the ecological intelligence that is actually a subject that we need to see for the future if we all want to have a healthy planet to live in, because we cannot be healthy if the planet is not healthy. So this concept is also adopted by the Eat Lancet summary report that I mentioned, and as Mr. Arkadianos mentioned, the planetary health diet. I do believe that this diet, for example, is very easy to be adopted by adolescents, exactly because they care more. They care more about animal rights, about the planetary health, and all these subjects.
Okay, thank you, Eleni. Now, I think I'll ask the last question since I said I have a question for Aspa. And I think, Aspa, you mentioned about the engagement of parents in school interventions and as being a very important factor. And I know that some of these kind of school interventions have not worked in the past because of the lack of engagement of parents. How can you motivate parents to take part in school and in general in community interventions? Some of the parents, it might be easier to do it at an individual level, but as a group, how do you motivate them to take part in these kind of interventions?
Yes, first of all, I mentioned parents because they are also role models for the children. And that's the idea behind having the whole school staff also being healthy literate, because this can help model the behaviors. But focusing on parents, we could explain why is this so important that they also apply these lifestyle changes in their diets. Parents would normally do whatever it takes for their children, and many times you've probably noticed it, that if you tell them something that they need to change something because it will help their children, they will do it. If we, for example, discuss the what I showed in the slide, how poor health is connected to poor academic performance, poor educational outcomes, this is something that can truly motivate the parents to see that more seriously. If we explain that a child doesn't grow inside their own bubble, but they are connected to what is happening in their family, this is something that can give them the intention and the motivation to change. And we see that also with many adult patients. They say, I do this for my children. So this is some motivation that works really well.
Okay, thank you. Thank you all. I think we will need to close this session now because we haven't taken more than we should. I think we have been all very good in terms of time management, but I think we've reached now the time when we need to conclude. I would like to thank all of you, Eleni, Annie, Aspa, Razan, for your excellent presentations and for the discussion. I think what we tried to get across to everybody is that if we want, if we manage to change the beginning of the story, we will change the whole story. And what we try to get across is that in order to change the story, we don't only focus on the child, but on their families, but also on their wider community and society. So thank you all for taking part in this discussion. Thank you.
Thank you.